All right, today we will be reviewing spinal cord lesions in pathology through the multiple choice questions. But before we jump into the question, I thought it would be useful to have a quick review of the anatomy of spinal cord so that when we discuss the questions, it make more sense. So spinal cord has this interesting disc-like structure or a long tube. And if you cut the tube, this is what you see from the top. And there is half in the middle, and each side is just a almost mirror image of the other side. So minimal variation. So if you look at the anatomy on one side, and there is exact same copy or replica of the anatomy on the other side, and of course each side is dealing with one half of the body. In the very center is the H-shaped of the motor neurons and motor axons. This looks more gray because there is the neuronal heads here, in addition to the axons of the white matter. So that's why it looks more dark. While the area around the edge, which is now split into three islands, so there's an island in the back here in this triangle shape, or both together will be a space between the upper half of H, an island on the side, and then an island on the anterolateral or in front and wrapping around the side here. Um, Now we can look at and all of these islands are basically the white matter, which means it's just the compacted axons of the neurons within the cell bodies are either within the gray matter in the center of the H or somewhere else outside or above the spinal cord. Now here, just for the sake of simplicity, we are looking at on one side of the body in red, the descending tracts or pathways that are coming down with the body's information coming down, and the ascending tracts on the other side in blue, although the exact blue can be copied over on the other side and exact red can be copied over on this side, and to form the full spinal cord. So if we look at the more detailed, exquisite detail of spinal cord, look at this picture over here with a lot of information copied in and even arrangement of the fibers from cervical spine and lumbar and sacral spine and thoracic arranged in different laminas with leg, thoracic, and tongue. But of course, we don't need to know the anatomy in that much of a detail. So we look at the simplified version here, and this one we're only talking about the white matter in this slide. And as you can see that the descending information coming the frame is basically two main groups. So there is the lateral corticospinal tract, which is the main voluntary motor control, which is bringing in information down to control the neurons that uh, are the final neurons that control the body, which are in the gray matter here. So this is the upper motor information coming down. And then there is also ventral corticospinal tract, which is also bringing voluntary motor information. And there's slight differences what information or which areas comes in the ventral corticospinal tract. But for practical purposes, you can forget the ventral corticospinal tract and focus on lateral corticospinal tract, which will contain most of the information for upper and lower limb and the trunk motor control. The ascending tracts are taking information up, and again, there are two main groups here. The posterior group here, which is called posterior column or dorsal column, and then the larger group that spans over both islands, the lateral and anterior white matter areas around the edge, which is the anterolateral spinal thalamic tract, and sometimes you can actually divide it into the lateral spinal thalamic tract and the ventral spinal thalamic tract, but for practical purposes, we treat them as the same. The dorsal column specifically takes information about vibration, pressure, which is sometimes called deep touch, and proprioception. But most important to remember is the vibration and proprioception, while the lateral spinal thalamic tract takes information for pain, temperature, and the light touch without any pressure sensation. This is the more detail of the laminas within the center H gray column and various nuclei. Luckily, this is not often tested. You just need to know that there is motor neuron and there is various nuclei here which are controlling different part. This will be more important if you go into neurology residency. And we mentioned the corticospinal tract that is coming down, and this is all of the brainstem where all of this ipsilateral descent and then decussation happens. And the main point to remember is that the very last slide at the bottom is the spinal cord, and you can see that the ventral column is actually ipsilateral, while the lateral column is contralateral or with after decussation. And again, ventral column is not very relevant to our discussions. And here again in the second picture, you can again see the same thing explained, and you can see the longitudinal descent in the brainstem and the deconcentration of most of the pathways that then travel down in the lateral corticospinal tract, and then they go at level by level into the gray matter and decassate with the motor neuron there, which will then give off a branch to control the skeletal muscle. Moving on, there is this is some of the details on what other pathways like the anterior corticospinal and then rubrospinal, vestibulospinal, reticulospinal, tectospinal pathways. These are also descending pathways controlling various parts of the body, so anti-gravity control, spinal reflexes, but this is less of a voluntary control and more of an involuntary reflex control. Posterior column is different than the lateral column in terms of the ascending pathways. The main difference in posterior column, as we, besides noticing that the posterior column takes vibration and proprioception mainly, is that it um, ascends ipsilaterally. So the bottom here is the spinal cord and E, and D immediately becomes the brainstem. And you can see as the green are the pathways, there is the nerve cell bodies for the first uh, level of the neurons, and first generation, first level neurons, cell bodies give off these axons that come in to the dorsal column and they ascend ipsilaterally. And they go on and then they do first synapse in the dorsal column nuclei, which is in the medulla. So right at the upper end of the spinal cord. And after the second generation nuclei, or after first interaction or synapse, that's where the decussation happens in the lower part of the medulla, and then it ascends contralaterally after that for decussation. And this pathway, that's where it ascends, is now called medial lemniscus, and it's going up all the way up to the thalamus, where all the sensations finally intersect. And then the thalamus will then give the third order neuron to go to the sensory motor cortex. So first order ascend all the way up to the medulla ipsilaterally. And if you contrast that with the lateral spinothalamic pathway or enterolateral pathway, when the neurons enter, the first order neurons in the spinal canal, at the level or slightly above the level, sometimes it is one or two levels above where they enter, they will synapse into the posterior limb of that H, that gray matter area. And that gray matter area has a second order neuron in the substantia gelatinosa and nucleus over there, which then give off axon that crosses over, decussates at that level where the second order neuron sits, which may be at the level of entry of the spinal nerve or above. So as a dorsal root, the neuron enters, but it's a very short axon this time for the spinothalamic pathway. So these are the neurons taking pain, temperature, and light touch, and then they decussate and then they cross over. And then the lateral, enterolateral spinal thalamic tract is all taking information contralateral from that level. And again, this crossing may not be precisely at the same level of entry. It may be one or two level above that this crossing over happens, and then it ascends ipsilaterally all the way up through the spinal thalamic tract in the brainstem. So now there is no new lemniscus formation, all the way up into the thalamic nucleus. And again, thalamus is where all the sensation goes. So this is the main difference between the two pathways. The second order neuron starts in the spinal cord and crosses over right there for enterolateral spinal thalamic pain and temperature pathways, while for the proprioception and vibration posterior column pathways, they ascend ipsilaterally first order neuron and only stops at the bottom of the medulla where there's the dorsal column nuclei, one nucleus for each of the two tracts, vibration for the upper and lower, more upper part and lower part of the body. So lower limbs and upper limb. And then they then decussate and ascend in medial lemniscus. So it's not called a tract anymore because this is a second order neuron. This is a decussation to separate from the dorsal column. And then they ascend in medial lemniscus all the way up to the thalamus. This is mainly the anatomy, and I will conclude with this picture of the nerves. As they are entering, you can see there is a dorsal root and there is anterior root. Anterior root is usually motor root, where the motor neuron is sending out the information, and the dorsal roots are. All right, let's start with our first question. A 30-year-old female comes to the emergency department due to worsening bilateral lower extremity weakness and numbness for the past 4 days. So, a very acute presentation in a relatively young female and of both lower extremities. She has had no fever, headaches, or back pain, but she had an incident of urinary incontinence today. So, there is also bladder involvement. The patient has no other medical conditions and takes no medication. So, no prior history. This is a new episode for her, 4 days. No fever, no temperature, and physical examination, no cognitive involvement, cranial nerves look fine, there's no facial weakness, upper extremity is normal, and then both legs are diffusely weak. And then the deep tendon reflexes in the legs are increased with extensor plantar response, or Babinski response is positive. So this means that there has to be some upper motor neuron features, brisk reflexes or hyperreflexia, not brisk, but hyperreflexia and extensor plantar Babinski response means that there is a lesion disconnecting the motor spinal control of the lower limb from upper limb. So there is a disconnect, but upper limbs are fine. So it happens somewhere in between the two in the truncal region. So upper limb is usually ends at T1 or T2, and the lower limb starts typically at L1 and L2. And so somewhere between that in the thoracic region, there is some disconnect that is causing a Babinski reflex and brisk tendon reflexes that started 4 days ago. And there is also sensory involvement. Sensation to pinprick is decreased. So that's the pinprick is the lateral, anterolateral spinal thalamic pathways below the level of umbilicus. So umbilicus is typically considered T12. So that means that right at so T10, sorry, will be the umbilicus. So T10, T12, just below T10 is there is the sensory lesion. Vibratory sensation is absent in the toes, which means that there is also some posterior column involvement. So which of the following is the most likely cause of this patient's current symptom? And so we don't have the options here. But let's think about this summarization. It means that it has to be a lesion in the spinal cord in affecting the upper motor corticospinal tract disconnect. Sensory level is at T10. And then below that, there is both anterolateral spinal and posterior involvement on both legs, bilateral. So it has to be a transverse or complete involvement of both sides of the spinal cord at that level of T10 or so. There has to be some form of a transverse myelitis and inflammation in the spinal cord that is diffusely affecting the spinal cord and not some compression from outside on one side or the other. So it could be an infarct, but it set in not suddenly, but over 4 days. So it goes more for inflammation rather than an infarct of the spinal cord at that level, but goes against any compression, internal or external. So quick onset, likely inflammation, could be autoimmune, could be infectious inflammation, but unlikely to be infarct. So let's look at the answer. And the answer is segmental inflammation of the spinal cord at the T10 or so level. A 65-year-old woman is brought to the hospital due to bilateral leg weakness and tingling for 6 hours. So hyperacute presentation in a relatively old female, 65-year-old. She has had new low back pain for 2 days. So, tingling and weakness started 6 hours ago, but some pain was going on for 2 days. She has obesity, degenerative disc disease, or arthritis, basically. She has had a hysterectomy for uterine cancer 15 years ago. So some remote history of cancer, so you always have to worry about recurrence of a cancer. Vital signs are normal. Spinal tenderness is present at T6 level. So there is some damage or lesion bony lesion or damage at T6 level. So spinal cord will not give you a tenderness, but the spinal column or vertebral column or bone will give you the tenderness. Lower extremity strength is 3 out of 5. Upper extremity is normal. So something has happened at T6 that is disconnecting the upper and lower extremities. Deep tendon reflexes are brisk in the lower extremities. I would recommend using hyperreflexia instead if you want to show abnormality, because brisk could be normal in someone who is anxious. MRI of the back reveals multi-level degenerative disc disease, likely not significant here, but there is a fluid collection that is spanning the T60 at area. So tenderness, fluid collection means that there could be some damage going on, and fluid collection usually means some form of an abscess. Fluid collection usually not used for bleeding. So if there was a hemorrhage or a bleed, it would have been reported so on MRI. Similarly, a tumor would not be called a fluid collection. Now, a tumor can have fluid levels in fluid pockets, but usually not a fluid collection. And the next step in management is emergency laminectomy and decompression. So it has to be some form of an abscess. But why emergency laminectomy and decompression? Emergency because the abscess, which kind of just suddenly grew to give back pain only 2 days ago, so maybe it has been building up but was not giving any symptoms, and pain was not what we are worried about. What we're worried about is bilateral leg weakness. Leg weakness means that there is some acute compression of the spinal cord that happened within last 6 hours, 6 hours ago, and that could get worse, and that could leave permanent damage if we do not relieve the pressure on the spinal cord quickly. So a spinal cord compression that happens very slowly over months or years from a disc herniation is usually not an emergency unless it suddenly slips. But any sudden decompression, a sudden compression of the spinal cord is considered very concerning, regardless of the cause. It could be a bleed, could be a tumor, could be abscess, anything that happens suddenly you need to treat suddenly because spinal cord have had not time to adjust to it, adapt to it, and will have permanent damages or scar tissues unless you remove the compression right away. So this is a neurosurgical emergency, and you literally have to rush to treat this patient and then and do other things. One other thing quickly I should mention is steroids, because when there is a sudden compression, there is a lot of edema or swelling of the fluid that worsens the compression. So it doesn't help. So you need to cut down that swelling and edema, and you give steroids like dexamethasone to try to reduce that edema so that some of that compression that worsened because of the swelling improves while you are preparing the operating room. You have to prepare the operating room. So 64-year-old woman comes to the physician with a 10-day history of progressive difficulty walking and poor balance. So fast, but not as fast as ours. So 10-day history, and it's progressively getting worse, and it's difficulty walking with poor balance. When there is weakness, the balance may be poor because of the weakness. So you cannot necessarily you may not necessarily have a separate ataxia or incoordination. Weakness often is, if it's significant, makes it difficult to say if there is underlying ataxia or not. 2 days ago, so after 8 days of this onset, she fell at home but did not sustain any injuries. Her chronic back pain is worse than usual. So she has a remote history of chronic back pain. Chronic means at least a year or longer, and is especially bothersome at night. She has no headaches, trauma, bowel bladder incontinence, or loss of consciousness. The patient's past medical history is significant for type 2 diabetes, hypertension, TIAs, transient ischemic attacks, and breast cancer status post lumpectomy, followed by chemoradiation 2 years ago. So out of all of these, the only thing that worries me is this history of cancer with lumpectomy. So they did not do the full mastectomy. So that means that they could have missed a small satellite lesion that could recur more easily, although she had a chemo and radiation done after the lumpectomy. But this will be a big concern. And she has a chronic back pain, but this has gotten worse. I'm not too worried about diabetes or hypertension, and TIAs is a very vague term that could mean nothing. Physical examination shows an unsteady gait, could be just weakness, bilateral leg weakness, increased deep tendon flexus, so meaning that it's an upper motor neuron lesion, that there is some disconnect above the level of lower motor control of the legs. So leg control starts at L1 or so. So there, above that is the truncal control or thoracic control, and there is some lesion there in thoracic if the upper limbs are fine. There is decreased pinprick sensation in both lower extremities up to the umbilicus. The umbilicus is about T10 or I think T10 or T12, probably T10, and that's where the level is for a sensory loss. And there is percussion tenderness over the lower thoracic spine. So percussion tenderness means that there is some damage to the bony part of the spinal canal, because spinal cord does not give you a tenderness, but the spinal canal, a vertebral spinal column, if there is a damage to it for whatever reason or cause, will give you tenderness, whether it be infection or tumor or fractures or whatever. Digital rectal examination shows good sphincter tone, meaning that there is no involvement of the cauda equina, and mental status and cognition normal. Which of the following most likely responsible for this patient clinical presentation? So something is happening around T10 area, which is involving a bony column and is giving a compressive symptom, but partial compression, not a full complete compression, which is presenting in someone who has a history of breast cancer in the past. So the question will be, is it a metastatic lesion from a recurrence of the breast cancer? Is it fracture, but there is no history of that? Is there any, her problem started 8 days before she fell? Is there a abscess there, but there's no fever and there is no, there is nothing palpable there, but infection cannot be ruled out. it's unlikely to be an inflammation of the spinal cord because that will not give you a percussion tenderness. Has to be a bone involvement to get a tenderness. So I will say metastatic lesion will be the highest concern, followed by infection either of the bony column involving into the spinal canal, or there could be an extra tumor there. Local tumor doesn't have to be metastatic, could be a local tumor there too. So let's see the answer. And the answer is spinal cord compression, which is likely from something outside the spinal canal, which they didn't say. I don't have all the options, so I cannot say why the other four options were not more appropriate or accurate than this. 57-year-old male who comes to the office due to several months of difficulty walking and progressively and lately weakness and stiffness in both legs has made it difficult to ambulate without support. The patient also has numbness and tingling in his arms and legs. So progressively difficult walking, 57-year-old male, several months, and now he's having both arms and leg numbness and tingling. His medical history includes hypertension, hyperlipidemia, not significant. He has smoked cigarettes daily for 30 years, concerning for a risk of lung cancer. He has used injection drugs in the past, so that increases risk of infections and including endocarditis or embolic infections and even infective emboli going to the spinal cord and so on and so forth. He has had several sexual partners that exposed him to risk of sexually acquired diseases like HIV. Temperature is normal, blood pressure is slightly elevated but not significant. Normal cognitive and cranial exam, mild weakness and atrophy of upper arm muscles with decreased triceps reflex. So there is some decreased reflex means that there is a lower motor pattern in the cervical area. Bilateral lower extremity strength is 4 out of 5, so very mild weakness. Vibratory and pain sensation is decreased in both hands and legs. So dorsal column involvement and pain sensation, so lateral spinal thalamic involvement, both hands and legs, so upper and lower hand involvement, mild weaknesses, and then there's atrophy of the arm muscles with decreased reflexes, means there is a lower motor involvement of the upper extremity for sure. Babinski sign is up going bilaterally, so that is an upper motor pattern. Further evaluation of this patient is more likely to reveal which of the following. So what does this man have? So there is clearly evidence of lower motor involvement of upper extremity, and there is involvement of upper motor with the Babinski sign being present. So it's a mixed upper motor involvement, both vibration and pain sensation involvement, both upper and lower extremity involvement. So this diffuse spinal cord disease. Now, there are two prominent things that come to my mind right away. The more commonly tested reason will be diffuse spinal cord degeneration, which is often taught around vitamin B12 deficiency, although that is not very common in clinical practice anymore because of routine use of vitamin B12 testing and replacement. So it's rare to have someone with several months of B12 deficiency in getting this. The other thing that will give you a mixed upper and lower motor presentation in both upper and lower extremity in this age will be ALS, or Lou Gehrig's disease or amyotrophic lateral sclerosis. By definition, ALS is involvement of both lower motor neurons and upper motor pathways, so corticospinal pathways. But what typically does not happen in ALS is that the sensory involvement is not seen. So patient has both vibration, posterior column, and anterolateral spinal thalamic tract involvement. So although there is upper and lower motor neuron disease that you can see with ALS, the sensory pathways are not involved in the ALS, which means that this has to be something like B12. Although other things can also give this subacute, several months combined, meaning both motor and sensory degeneration of the cord. So subacute combined degeneration of cord, or SCD. B12 is the classic cause, but there are many other things that can cause it. Let's look at the answer. Advanced spondylosis of the cervical spine on the radiography. So that's a very good point. I think that the reason I missed it is because I probably presumed that there is lower motor involvement of the lower limbs, which is likely not the case here, but I did not pay attention. And there is no bladder involvement given, and there is no balance involvement. Well, there is difficulty walking, I guess, which I probably assume with leg weakness. With 4 out of 5 leg weakness, I should not have thought about difficulty walking due to weakness. So yes, cervical spinal cord compression from cervical spine disc degeneration or disc herniation. Spondylosis means that not only there's disc herniation, there's also slipping of the vertebra on top of each other. So if one vertebra is stacked onto the other and they're slipping, one is coming forward to the other, then that creates a very kind of an S bend in the spinal canal like this. So then there will be a severe compression of the spinal cord because of this, and that will give a lower motor pattern at the level of compression. So triceps reflex is typically C7, T1. So that will be the level of the spondylosis, and then below it, it is giving upper motor neuron sign. So yeah, I mean, there are, the question is written accurately, although it does mislead you to a wrong answer.